Bom dia a todos e todas. Eu sou Carolina Mulan, professora da Universidade Federal de Minas Gerais e secretária executiva da Associação Brasileira de Relações Internacionais. Estamos hoje muito felizes porque estamos encerrando, o nosso 5º seminário de pós-graduação com essa mesa e esse debate fundamental para a nossa conjuntura, que é pensar a centralidade da área de relações internacionais para as reflexões e para a relação com a atual pandemia do Covid-19. Temos a honra de receber a professora Sarah Davis, da Griffith University. A professora Sarah é Australian Research Council Future Fellow, é professora também do Center for Governance and Public Policy da School of Government and International Relations da Griffith University na Austrália. Os seus interesses de pesquisa são a governança global da saúde, os temas da diplomacia da saúde, prevenção da violência sexual em situações de conflitos armados. Sarah tem uma vastíssima publicação no nosso campo, já publicou na Review of International Studies, na Security Dialogue, na International Affairs, que são 3 revistas de ponta da nossa área. Ela também tem um livro publicado On the Global Politics of Health, pela Polity Press, e uma publicação, um livro chamado Legitimizing Rejection, International Refugee Law in Asia, por uma editora holandesa, e é coautora de Disease Diplomacy pela Johns Hopkins University Press, com Adam Scott e Simon Rushton. Para debater a apresentação da professora Sarah, nós convidamos, temos a honra de receber também o professor Henrique Menezes, da Universidade Federal da Paraíba, que tem um belíssimo livro recém-editado pela editora da Universidade Federal da Paraíba, sobre os Objetivos do Desenvolvimento Sustentável, que em breve estará aí falando no nosso canal da Abre, sobre essa importante contribuição ao nosso campo. Eu queria agradecer, antes de passar a palavra para os nossos panelistas, agradecer a toda a organização desse seminário, em particular a gestão da Abre, liderada pela professora Deise Ventura, os coordenadores e coordenadoras, e vice-coordenadores das áreas temáticas, os mais de 200 alunos de pós-graduação e graduação que apresentaram seus trabalhos, na galeria de pôsteres, mas também nos diferentes painéis. Foram 3 dias muito prolíficos e acho que com debates que mostram a vivacidade e importância do desenvolvimento do nosso campo de estudos no Brasil. Queria agradecer também especialmente ao apoio da Friedrich Ebert, a Fundação Friedrich Ebert, que nos ajudou e tornou possível a realização desse seminário em condições tão difíceis, essa modalidade virtual. Então, agradecendo à Fundação pelo apoio e possibilidade de nos mantermos conectados e próximos, manter a nossa área viva nessas circunstâncias. Thank you very much, Sarah, for being with us. It's very late in Australia, so it's a double thank you for engaging us with such an important contribution to IR and the pandemic, and for initiating and strengthening the dialogue between Brazil and Australian international relations scholars. So thank you very much, Sarah. I'll let you do your presentation, and then Henrique and I will engage some questions, and especially I'll be reading the questions and comments from the audience. So thank you very much again, and the floor is yours.
Thank you so much, Professor Mulan and Professor Menendez, for the invitation and for agreeing to help me close your session of ABRI. I've been watching on Twitter, and I've been really just captivated by the amazing research that is being presented over the last week. So I really am personally honored and grateful for the chance to be able to talk to you all for your closing session. And I sincerely apologize for my Australian accent perhaps ruining any pronunciations that I should have done better just then. And I also sincerely apologize for this being in English. I'm sorry. I'm going to quickly now share my screen, and hopefully this will work. I just would like to... No, it's not going to work. I can't see my PowerPoint coming up. This always happens, doesn't it? My university has a, I shouldn't say this, but we have a drinking game every time that there's a problem with trying to be able to get a screen share to work. We always go, right, you owe me a beer. So right now I owe you all a beer. Hopefully now this will work. Here we go. So everyone can see this, I hope. So I'm here today to talk about international relations in the time of COVID-19. But before I do so, it's really important to me personally to acknowledge country. So my university and my home lives on the land of the First Peoples. And so I acknowledge the traditional custodians of the land on which I am here meeting with all of you. And I pay my sincere respects to elders past and extend my respect to all the Aboriginal and Torres Strait Islander people. I am residing today on the land of the Turrbal people, and I pay my respects to their elders, past, present, and emerging. I would also like to acknowledge the loss of lives due to COVID-19, acknowledge the recovery of survivors, the essential care and labour that is being provided, and acknowledge the economic, social, physical, and mental harms that have occurred during the COVID-19 pandemic. Today, what I'm going to be talking to you about is an article that Claire Wenham from London School of Economics and myself wrote for a journal, International Affairs, and it was published 2 months ago now. And we wrote this article partly out of a little bit of frustration, I think I can say, on Claire's behalf and mine, but also concern in terms of what we felt was the narrative that was emerging, particularly in the first 6 months, around COVID as a health problem versus a political problem. So the pandemic caused by, novel coronavirus COVID-19, in this article we wanted to argue is as much a political problem as it is a public health tragedy. Politics has been at the core of how governments have prepared for and responded to this crisis. Political decisions have beleaguered or improved outbreak management, sometimes irrespective of the strength of a healthcare system, clearly demonstrating the political determinants of public health. And it's clear from the different government responses to the outbreak itself. The technical decisions require political decisions about who should be consulted, who should provide advice, which models should be used, what policies should be implemented, and how such policies should be enforced, and who can be trusted. Politics is deciding how COVID-19 is spreading and whether people live or die. And the political tensions are not limited to the domestic arena, as we see here. International organizations, specifically the World Health Organization, has been operating in a combative and diversive political realm. There have been proxy battles waged within the institution between member states, particularly China and the United States. And there's always this tension for the World Health Organization of either being too political, in this context in bed with China or the compliant and an accomplice to China, or not political enough. And the politics of orchestrating the multiple demands and expectations of states within one international organization, though, is proving so vital for the management of COVID-19. These geopolitical tensions are not new, but we were concerned, and we do raise that this article was written out of frustration. The sense that the WHO has been seeking to try and create this apolitical structure around health emergency response. We suggest with great respect that this premise is perhaps a bit misguided, and it may be indeed have unwittingly contributed to crisis of confidence that we sometimes see and have seen in the World Health Organization. It also came out of our personal experiences where we had been regularly asked to talk about COVID-19 to media in particular about the international relations outbreak of the outbreak response by states reporting, testing, responding differently, heeding advice. And it struck us, and it struck a number of our colleagues, that we're rarely asked these questions by the World Health Organization, even by public health officials, sometimes seeking to refine their response efforts. And we wondered if maybe one of the problems here was that social science is not necessarily being read by those in public health institutions, and that the public health and global health security communities have remained in separate silos. And so this article was written out of this very desire to try and break down that silo and to argue, make the case for the study of politics to achieve international cooperation and solidarity in response to COVID-19. So as I said before, this presentation is based on a paper that Claire and myself wrote, where we really do seek here to reach out across the divide between public health and IR communities. We really want to try and establish what cooperation the international relations scholarship can make to the real-time decision-making during outbreaks, but also in the post-hoc analysis of these emergencies. We argue that there's simply not been enough recognition of the normative value of diplomacy in the preparations for health emergencies by WHO or by states. And this deficiency in that kind of diplomatic preparation is now having real world effects on the chances of infection and indeed survival. In this article, we talk about the fact that there are really important diplomatic entry points, and I'm going to present those to you today, which we think can provide the opportunity for disease diplomacy and cooperation to be advanced. And we think that IR knowledge brings something extra to, at the moment, a lot of focus on technical health responses that seems to be the primary focus of the World Health Organization. I present this in 3 stages. So in the first stage of this talk, I'm going to talk about the surge of COVID-19 and how the World Health Organization's effort to try and avoid politics was ineffective. Politics found its way in. Second, I want to talk about the World Health Organization's mandate, the path dependency and the pathology, and how WHO has tried to orchestrate expertise as separate to politics. And this has resulted in a neglect of the fact that there is a politics of expertise that is occurring. And that's been quite damaging, we think, that neglect for the World Health Organization. And finally, we want to make the case for bringing IR knowledge into health emergency response. And so I'm going to briefly present to you 5 entry points that we present in the paper as being areas for cooperation and engagement between World Health Organization, national governments, foreign policy and diplomatic expertise around the area of health security. We think this is an opportunity here for us to think about building knowledge and expertise in the health terrain around politics. And I will want to add the caveat here that our characterization of IR and in the paper is a purposive policy engagement. We want to produce policy relevant research, but we hope that this piece and what I'm saying today is grounded in theory, empirical research and practice. I should acknowledge that I see myself more theoretically aligned with constructivism and feminist approaches to international relations, and that certainly has informed what I think are the key entry points that I'm going to be presenting today. So I'm not going to say that this is the only message of the type of entry points that can be happening in the area of IR and health cooperation. We actually want to start a much deeper conversation about where is the contribution. And so I look forward to hearing your thoughts on this. So from the very beginning, the key tenets of international relations have dominated this outbreak. Cooperation between states and the World Health Organization with COVID-19 has really dominated the narrative from January 2020. Dr. Tedros was already working like a diplomat with pains to stress that China was cooperating, that WHO did not support any restrictive trade or travel measures being adopted against China. And this emphasis was no doubt fueled by a desire to ensure that China continued to engage in a transparent reporting relationship with the World Health Organization, so that it would get the much needed data from China about the scale of the outbreak and understand then what type of prevention and treatment options it could suggest. The politics of how the World Health Organization managed that relationship in that month has been hotly contested and still is to this day, and is subject now to this independent panel review. The question that may be asked of many member states, though, is how else could the World Health Organization have tried to have managed a very difficult technical and diplomatic relationship at a time where knowledge was still very delicate? On the 22nd of January, the International Health Emergency Committee themselves was split when they first convened to discuss whether or not this was a public health emergency of international concern. And to achieve that split, you have to have, a fair amount of members on the panel divided, and that was indeed the case. So it's not that it was just the representative of China opposed calling a FIC. There were other executive committee members who were present who did as well. They didn't think that it was yet, there was a case to be made. A week later, when the FIC was declared, Dr. Tedros was, of course, again, at very much pains to stress that this was not about making a declaration about the risk within China itself, but this was about the fact that the risk of the disease to low and middle income countries with weak health systems could lead to a major epidemic. By March, the World Health Organization was now under very strong public criticism for being seen as appeasing China's actions. This included, now it was becoming revealed by then, that China had been engaged sometimes in forced lockdowns that had led to police threatening medical staff with arrest for online communication about the outbreak. There had been a lot of issues around the forced quarantines and lockdowns in the cities, and the failure to perhaps recognize and address and mention the fact that some human and civil rights abuses may have been carried out to achieve such strong lockdown interventions. At the same time, though, there were a number of countries that were starting to challenge the travel and trade measures that are not meant to be arbitrarily applied at the call of a FIC, which these states were now starting to adopt. So the United States, Australia, and New Zealand were doing so, and this was being met with relative silence from the World Health Organization. So again, there were states engaging in activities that weren't necessarily in accordance with the regulations, and the World Health Organization was silent. And in fact, Justin Trudeau, the Canadian Prime Minister, said, "We recognize there are lots of countries making different decisions, but the decisions that we are making, though, are based on the recommendations of the World Health Organization. There's a lot of misinformation out there, and there's a lot of knee-jerk reaction that simply isn't keeping people safe, and this is having real challenging impacts on our communities." By May 2020, the WHO Director General had not called out any state for failure to heed WHO's advice. Since then, we've seen some stern language introduced in the face of suggestions about herd immunity. We've certainly heard suggestions about the need to roll out community testing, but there has continued to be a reluctance to call out states for failure to comply with the IHR and with the recommendations the Emergency Committee are providing. Even when now the famous attempt of President Trump to terminate relationship with the World Health Organization in June 2020, Dr. Tedros was still publicly stating a desire to continue to collaborate with Washington. So the trust of states in the World Health Organization as the best delegated authority to steer the international community through COVID has certainly been tested this year. We should remember, though, that it has been tested in the past. It was tested after H1N1 response in 2009. It was tested during the Ebola outbreak in 2014 and 2015. There is always variation in how states adhere to the WHO's trade and travel advice, and not all states are going to follow the procedures recommended by the World Health Organization. The lack of recognition of WHO's authority to manage COVID-19, however, is being really starkly demonstrated in this crisis situation. And it's suspicious that the World Health Assembly did agree in May 2020 that the World Health Organization should initiate an independent evaluation, a lessons learned, of how it has responded in the first surge of the COVID-19 outbreak. The creation of the Independent Panel for Pandemic Preparedness and Response was announced as being due to a desire to seek lessons that need to be identified. And Dr. Tedros said that he welcomed the panel because it was the chance to recognize the fact that the greatest threat to COVID-19 response at the moment was the lack of leadership and solidarity at the global and national levels. However, Richard Horton, editor of The Lancet, published a piece that same year talking about the fact that global health is typically agnostic about the kind of political system a country should choose to adopt. Global health and its institutions still see health systems as separate, technically, socially, economically, from the political ideologies of nations. This view is simply not sustainable. We cannot say that the terms of political engagement within a country are relevant to our hopes for health. As IR scholars, we know that global health institutions can never rightly be viewed as separate from politics and political ideology. The conviction that health could ever be apolitical, in spite of the abundant evidence to the contrary, reveals for us the fact that health is only coming up to this now is a little bit concerning, and that perhaps health disciplines hasn't really been engaging with IR research, which has for a number of years been documenting from the UN AIDS to Gavi to the World Bank to PEPFAR to UNMIA with the Ebola emergency response, that there really is a politics of health and a politicization of health institutions that have been occurring for a long time. The concern for us also was the idea that still continues to this day, as that quote from Dr. Tedros and as this quote here from Jenny Harries maintains that we can continue to have a World Health Organization that can operate seemingly above or separate to politics when it's clearly mired in it day to day. So as IR scholars, we really want to try and help in this instance, humbly help. We want to look at the orchestration role of the World Health Organization. How can it try and manage the multiple competing priorities and approaches of states? And we think it's important to note non-state actors as well, working in the global health governance landscape, to support the structure, agency, and preferences that are needed to mobilize states and organizations to act cooperatively, rather than as these random billiard balls bouncing into each other that we have been seeing during the COVID-19 response. We think now is the time to talk about how political analysis can actually enhance global disease efforts. We don't need to be quarantined. We can be brought in. As a feminist IR scholar, I understand that decision on who has a seat at the table is a really powerful and conscious decision. It's a political one. Within emergencies, invitations to the table can come down to personal, professional, and strategic networks. It's who you know, it's who you respect, it's who you fear by not having them in the room. The absence of IR knowledge and expertise, we think, from the way in which the World Health Organization assembles its experts, is problematic. It's problematic for pandemic response, as it means that the political contents of representation, power, and inclusion can be overlooked, treated as secondary to the normative value and honor of technical epidemiological advice. And we think this form of knowledge triage has implications. Leadership and governance has been identified by public health scholars as two areas where perhaps there could be work done to improve state capacity to respond to outbreaks. And I'm quoting that from an article that was published last year. Performance in governance and leadership is often measured in terms of the presence of national laws or regulatory frameworks, transparent decision-making structures for federal or centralized systems, evidence-based risk communication channels, and some national level collaboration system that includes a whole of society approach. Transparent and coordinated leadership and governance may well assist during any emergency response, but a leadership or governance checklist will not always tell us how a state will play with others in the global system. And we see this through the Global Health Security Index, which placed the United States and the United Kingdom in the lead for outbreak preparedness. And clearly these two states have not achieved that in response to COVID-19. Our concern with the way in which governance and leadership is understood in the health realm is that they seem to think it exists in a timeless governance vacuum. States may stay the same, but its government will certainly change. Governments will exercise their responsibilities to health governance exclusively through health ministries and membership of the World Health Organization. There are competing transnational forces at work, though, here. Economic stability or instability, a once-in-a-century crisis that will pull at loyalties, interests, and trust relationships of the international community. How will cultural, gender, racial, economic dynamics affect how a state will view themselves, their neighbors, their place in the world in response to this crisis and as this crisis unfolds? we need to really know more about these political effects and to take them seriously as affecting the type of health messaging that is trying to be delivered through the World Health Organization. There should be, we think, at the core of public health advice, being an international relations informed understanding of why states would want to delegate their authority to the World Health Organization to coordinate public health response and public health action. To seriously ask that question, why would states want to delegate their authority to who? As the COVID-19 outbreak has progressed, the majority of domestic governments have proceeded alone, sometimes independent of the advice offered by WHO, sometimes to try and make a point of the fact that they're doing something different to the World Health Organization's advice. These actions have not only put multilateral cooperation at risk, in a time where we're already seeing global supply chains, trade routes, and international diplomacy under extreme pressure, it's also having a massive impact on securing populations and health systems until there is a vaccine. And then the worry then about how are we going to coordinate and who is going to coordinate health diplomacy when we do hopefully achieve a successful vaccine and vaccination supply chain. There is a lot of literature on the World Health Organization about its governance arrangements and its management of states' collective individual expectations within as one of an example of the pathologies of international organizations. And here we think, again, it's really important to think about when states choose to delegate authority to separate organizations such as the World Health Organization, it's about institutional capacity. It's also about moral persuasion. It's also about enforcement mechanisms. So when two states, irrespective of the political complexion of their powers, when do they choose to respond to a problem with collective action rather than go it alone? As states have diverged from WHO advice during COVID-19, we think WHO needs to seriously engage with health diplomacy to try and understand and think about how did these differences occur? How can they, as the third actor, try and orchestrate cohesion over the differences between states, rather than trying to impose a truth or scientific knowledge upon them that doesn't necessarily take into account the fact that you have material, normative, and strategic competition going on here around the norms, rules, and practices of what should be guiding that state's behavior. And one of the things that we talk about in particular in the article is the fact that an illustration of this is the way in which the international health regulations has a set of 13 core capacity criteria that states are measured against to see whether or not they are meeting this checklist in the area of legislation, finance, training, laboratory preparedness, etc. One of the things that is concerning to us is that what isn't necessarily looked at in these studies and these evaluations of whether or not states are meeting their capacities, which are done through what's called a joint evaluation exercise, is the structural questions around how the contemporary political picture of that country, the governance capacity, the human rights capacity within that country sits against the operationalization of these IHR core capacities. The vast majority of knowledge gathered through the IHR JEE, or what's called the eSPA website, which is where they measure core capacity performance, looks at these technical proficiencies. A state's capacity to meet the IHR has been separated from its political, economic, diplomatic, and human rights positionality. And as the COVID outbreak has shown, the WHO's attempts to try and ascertain state capacity primarily through public health indicators neglects this broad range of historic, economic, political, and social institutions that support implementation of the international health regulations and support response to a health emergency outbreak. We think this stems from the way in which the World Health Organization has been positioned for a long time now through its mandate to privilege scientific knowledge, health expertise, as the priority of the way in which it thinks about and manages its work and its authority. And we think the consequence of that is the way in which WHO thinks about its authority as a conductor tries to ignore the potential of fractious politics. But we think that it's that ignoring the politics that has actually led for states to actually question its capacity to conduct health diplomacy and to conduct a response to COVID-19 that recognizes the competing sorts of diplomatic tensions and priorities of states. We want to suggest that there is a place here for the World Health Organization to try and think about, while holding on to its mandate of health for all and holding on to its technical proficiency in public health, to reach out beyond and think about the geopolitical and diplomatic relationships that inform the interpretation of health advice. We think IR knowledge methods and inputs should become core business for the way the World Health Organization and perhaps other technical agencies coordinating responses to public health challenges. And in the paper, we go into a bit more detail and how we think that this could be done and could become a compartment in particular of the joint evaluation exercise assessments. What I want to do now is, brief for the remaining time of my talk, is look at the entry points for international relations and health emergency planning and response. International relations deals with the interrelationship between domestic and international politics. In any kind of emergency, including a health emergency, it's really important to have an understanding, we think, of the contemporary political environment. To not assume that this knowledge is common sense, that it's static, or that it can be easily aligned with what a country did in the past. Politics changes domestically and internationally on a daily basis as governments and non-government actors react to new events, to changes in politics, to changes in leadership. And every health outbreak situation deserves recognition as being politically unique. Every state has dynamic priorities, genders, and conditions that may affect its response to an emergency that may be different to how it responded in the past. And the invitation to international cooperation will be received differently from one year to the next. And we think technical organizations like WHO need to keep track of these diplomatic conditions with their member states that may enable or constrain state cooperation during an emergency. The way in which the World Health Organization is structured is to deal with ministries of health and to think about its engagement through that one channel. We think, though, it's really important for the Secretariat, for the headquarters, to give some more importance to the inclusion of diplomacy and understanding of states as part of its core work. And we think international relations can offer entry points for helping and assisting with this understanding of cooperation and coordination. One option we have suggested in the paper is to think about how could we create, as a discipline, a politics in health emergencies or a politics in emergencies service, similar to what we've seen with the Social Science and Humanitarian Action Service, which was established in response by anthropologists to the Ebola outbreak in West Africa. Anthropology saw the need to facilitate communication between the World Health Organization, between the communities in which it was seeking to gain entry and trust. And it saw that there was a gap there between the governance arrangements, sometimes in states, the civil society arrangements, and the World Health Organization itself. It needed to connect those interactions. And we think there's a potential need for us to do that here. There's a need for there to be the World Health Organization to have the chance to be able to interact with other agencies, particularly ministries of foreign affairs and international development, and to be able to engage with other types of actors that may be able to, particularly civil society and human rights actors, that need to be able to be informed and part of the message around health emergency response and recommendations. We have already seen during COVID-19 calls for the creation of advisory groups at the national level. For example, Germany has referred to the need to create a post-crisis recovery specialist group. And I know that there's a lot of discussions at the moment in there was a recent piece in CSIS about how that may need to be considered in vaccinations as well, about developing a more plural group where there's a subgroup here of experts, but also human rights and minority populations that are part of the collective and informing what type of responses at the national or subnational should be happening. And we think that the World Health Organization should engage with similar types of initiatives. We suggest it's time for the Secretariat to revisit this preference for health professionals and seriously engage with these variety of experts that could inform them. And there's a precedent there because we have seen anthropologists called in to report to IHR committees and to help inform with the types of continued advice that these committees provide. Why not seek the advice of human rights, of diplomacy, of politics, and thinking about the recommendations that are going to be delivered by that executive committee? The best surveillance system, the best advice is quite futile if governments do not feel that the advice reflects or is taking into account their position. We also think that there's a need as well for the World Health Organization not be seen sometimes as politically supporting through silence what is sometimes a Potemkin village. So we suggest 5 tangible entry points through which the IR can contribute to international organizations and even, we think, state governments in health emergency response. The first one is in comparative politics, because we say politics is not the same everywhere. As you all know, every state is unique. This requires looking at executive, legislative, and judicial branches of government, decision-making power and how it's being diffused amongst actors, the types of trust that exist between institutions. This type of work is being regularly done by political scientists and comparative analysis, working in conflict and humanitarian conflicts, and thinking all the time about how to navigate institutional differences and tensions. What we say in the article is knowing the sweet spot for interacting with a particular state can be vital when you're trying to build relationships and mitigate risk in a crisis response. This type of knowledge, we think, could be really useful for embedding in the way in which the World Health Organization operates on a daily basis as part of its exercises when thinking particularly about preparations for health emergency response. In peacetime, to be working with political scientists to know the landscape of the health and political sectors in a given location, so that when they're having to assess surveillance that's coming in, when they're listening to the types of non-state reports that are arriving, they can start to have conversations and they can start to engage with what types of systems and what types of informal and formal institutions could be informing their response to the information that's coming in. Failure to think about governance has real-world implications. During the Ebola outbreak in West Africa, it was the lack of governance knowledge on the ground that exacerbated the haphazardness of WHO headquarters response in 2014, and especially. And that was why we saw in response, UN Secretariat in New York talk about with some member states the creation of an UN institutional response, UNMIR. Political analysis within the WHO prior to these actions maybe could have noticed, for example, that there had been reports coming out from the UN mission in Liberia as early as June, and the UCHA, the Office for the Coordination of Humanitarian Affairs, that there was this need for them to coordinate with the World Health Organization in thinking about the response to this humanitarian agency, this humanitarian emergency. We felt that when you go back and you look at the sequences of events there, that effort to try and connect World Health Organization's knowledge of the public health situation with the political, as well as with the emergency situations and the conflict situations that were already occurring there, could have identified a hybrid governance mechanism that could have led to better information and more quicker response. Political expertise is really highly pertinent in disease outbreaks, because what it allows is also to acknowledge the fact that you are going to have different agendas and competing interest groups operating there. So at the moment of crisis, knowledge of that complexity can be invaluable. It avoids wasting time. It also is an added value. It's an added value to the World Health Organization to have this knowledge. It also, we think, makes you as an outsider more aware of the fact that there is a whole understanding of local authority that can align with particular social movements, groups, religious denominations. Governments may not tell you this, public officials may know but can't say, and scientists may find the political scene just an endless irritant, or a serious threat to their independence. Again, the World Health Organization, we think, has a responsibility to pay attention to these environments and to think about the social messaging and the risk communication in this area of statecraft. The second area that we think is really important for the World Health Organization to receive information on is on collective governance. Disease outbreaks reveal some strains on collective governance, and we think COVID-19 in particular has revealed strains that were already there. But the study of global governance also tells us to think about the World Health Organization as sitting within that larger international ecosystem. It needs to understand that it's part of this bigger picture. And we think that kind of framework of thinking about how the World Health Organization positions itself, not just in the global health governance space, but in the United Nations agencies and organs space, allows them to the folk to consider what has worked, what has been challenged by member states and other areas. How can lessons from other areas where there's been an attempt to try and bring technical cooperation can lead to enhanced authority for that particular organization? In-depth analysis of the World Health Organization and its position within the global health landscape, we think, is really vital right now. The system, the international, the multilateral system is shifting quite a lot. As it's been often noted, COVID-19 occurred in an environment where there was already immense strain occurring through a lot of our multilateral organizations. So providing that nuanced understanding of then how the World Health Organization was going to be best positioned in health emergencies and what types of actors does it need to try and seek and engage with, what types of regional versus multilateral organizations can it have as friends, is something that we think is really important. And that's predicated on understanding that there needs to be attention paid to the global regulatory and legal frameworks that don't just operate around disease control, but operate around international relations and international organizations. So one of the things that we argue is really important here is for the IR scholarship to be invited to look at, yes, the state compliance in reporting disease outbreaks to the World Health Organization, but also to think about other examples of where there have been conditions where states have cooperated and willingly participated in global forums because it has direct benefit sometimes for them to participate. This is kind of IR scholars' bread and butter, thinking about how and when governments cooperate, how they participate, how they organize and structure themselves as a bloc, and sometimes when they decide to go it alone. We think that this is a really important area to look at. And we argue in the paper that if you look at the virus sharing dispute that happened between Indonesia and the World Health Organization in 2007, you can see that, looking in hindsight, that for Indonesia, this was a vital moment to be able to secure not its sovereignty over a virus, but also to secure its chance to be able to make sure that it could have access to a treatment for an outbreak that was particularly affecting it, which the country knew it didn't have a lot of relative power in the system if it didn't hold back the virus sample. We also think as well that this would provide this type of analysis of when states willingly share data and surveillance and when they don't, would then lead to also a better understanding of then when is the right moment to go public with states versus trying to keep and continue that quiet diplomacy. We suggest that the World Health Organization hasn't really made these issues around trying to elicit information very public. And as a consequence, we can't really study with any sort of rigor, how do you build cooperation and what are the cases where you could maybe introduce earlier tipping points. Public health officials know states are not the same, but IR studies why states are not the same. And so we think that, again, there's this real area here for us to be part of the movement of studying the political levers and pulleys around health cooperation. The third area is political economy, and here we think it's really important to talk about money and power. The increased contribution to the WHO's voluntary budget over its core budget has meant that you now have a situation where there are powerful funding actors who increasingly decide the focus and direction of the World Health Organization's programs, while its core program becomes smaller and smaller and smaller. At the same time, you have states such as the United States and China and others sometimes preferring to run their own bilateral health aid programs rather than contribute to the World Health Organization. And this was happening before COVID. The World Health Organization hasn't necessarily been getting the first call or the first injection of cash for some time. It is in a precarious financing situation. It has underfunded assessed contributions. It has very little power to be able to exercise authority over states to contribute more to its budget. The legislative power granted to the World Health Organization under the International Health Regulations, for example, talked about the need to introduce a funding mechanism that has never yet really seriously arrived to help the World Health Organization advise low and middle income states on disease surveillance and response. We think it might be time to confront the fact that, sadly, the World Health Organization may never have the financial support it needs to implement all the activities that it might wish to undertake to improve public health. States know this, and it's possible the institution knows this as well. We shouldn't look to the Trump administration's cessation of funds and then hopefully the restoration of those funds as a solution. We think that the World Health Organization has to manage the fact that precariousness could be its future. And the argument for more money is getting tired. No agency, sadly, is getting more money. And after COVID-19, that could become a pattern. So for us, again, the World Health Organization economically needs to start having a serious engagement about its economic reality post-COVID-19. The financial environment is going to be more constrained. So again, the focus on how the World Health Organization does its cooperation best, where it receives most support for its health diplomatic role, how can its governance arrangements in development with other organizations in the global health space and across the UN space can be improved, we think will become a really important focus for the World Health Organization in the next decade. There's certainly a diplomatic balancing act in these types of conversations that requires the World Health Organization to think about its normative and technical strengths, as well as its scientific rigor. But we think in the post-COVID-19 world, the world who will have to embrace these new forms of collective power, hybrid governance arrangements, to try and maintain the small amount of funding that it currently has. And again, we also think that there's an opportunity here to think about how regional and sub-regional diplomatic engagement, cooperation and planning could create alternative forms of communities for the World Health Organization to still carry out its work. The fourth area is human rights. And here we want to talk specifically about trust and information. Within the formal and informal governance, within the governance of outbreaks, trust becomes of paramount importance. It's important in terms of how the country is formally legislative to be able to support the rights of its citizens, but also in the informal ways in which people behave, interpret, and act upon the information within their society. Broader IR scholarship has thought a lot about the theme of trust, and these insights have had applicability, we think, to the understanding the outbreak response. Communities need to trust public health advice, and they also need to be trusting the authorities providing such advice. And the outbreaks have shown that there are different sources of information that are accorded different degrees of legitimacy. And this has been the very core of the debate around infodemics, the use of masks, and going to be a big issue around trust in vaccines. Trust in actors with supposed authority in health emergencies, trying to manage differing legitimate information, trying to manage the politics sometimes around the advice given by politicians, is all kind of the work that we've been doing for some time now in health security in the area of HIV/AIDS, as well as the Ebola outbreak, as well as the preparations that were originally being done for an influenza outbreak. There's a lot of knowledge out there around the tensions and risk communication failure that arises when government public health campaigns are introduced in locations where governments do not have authority or do not have trust amongst the populations who are particularly at risk. We think, again, that there's a really important need right now to turn back to those studies and to pay serious attention to the work that has been done around trying to understand the relationship between trust, civil and political rights, intersections, and advice and following with health advisories. because we think that neglect of the importance of understanding that information and access to information is as much a part of political control as it is about being able to access that information in the first place, is really important if the World Health Organization wants to claim that it recognizes this relationship between human rights and outbreak response, which it says it does in the international health regulations. In the technical spaces of infectious disease surveillance and response, we must be attentive to the civil and political rights space in which healthcare workers, scientists, non-government organizations, and the media work. And one of the things that we argue that has been long neglected in the World Health Organization space, particularly in the health emergency response space, is thinking about the civil and political rights environment in which these first responders are having to work, and how that can sometimes affect their freedom to report, affect their information that is being provided up through government, and then the information that's coming to the World Health Organization. We really argue here that there is a need to carry out a systematic and sustained review of state practices around their human rights obligations during health emergencies, and to be monitoring that as part of the international health regulations framework. Considerations of the human rights challenges on particular communities is really vital if we're going to be thinking about how this advice, particularly going forward around the area of vaccinations, is going to be received and understood and acted upon. Finally, we look at gender inclusion as an important area of entry point in health emergency response for the World Health Organization to more actively engage in. One of the things that we've found really sad in a lot of the health emergency response is the absence of gender perspectives and gender considerations in the way in which data is collected and in the way in which advice is delivered. Representation of women in particular is noticeably absent from the international health regulations processes up to the COVID-19 outbreak. Even in 2020, the sex differences of COVID-19 and the gendered effects of COVID-19 are still very hard to examine, owing to a lack of real-time sex-segregated data that's being made available during the course of the outbreak. What it means is that when we're trying to think about the distribution of the disease, the impact that it's having, the way in which different populations are, the behaviors around going to get tested and then being contact tracing, and the impact of the disease on populations, we simply don't have enough of that data. We think that the World Health Organization could play a really important normative role here in promoting and normalizing the collection of sex-segregated data. And we think really up until COVID-19, a lot of that conversation from the World Health Organization has been too silent. And indeed, we also agree that there are a lot of the way in which the work, the informal and formal healthcare roles that are provided primarily by women in health emergencies has also been silenced for too long in the health emergency space. Women in particular contribute a lot of reproduction labor, informal care that is vital for not only home care, but also often community care. It's unpaid and it's unrecognized, and yet global health depends upon this labor. We think there needs to be a lot more discussions about the representation and inclusion of women and gender, not only into decision-making roles, but also into those types of advisories that are being developed by executive committees around how communities should be acting and responding to disease outbreaks. So in conclusion, what I would like to say is that we have the need right now to be able to think about the response to COVID-19 and what we want to see after this. The World Health Organization is a magnet. It brings states together to discuss and collaborate on all matters of health science, and has done for over 60 years. Of course, the World Health Organization has relied on science to persuade its member states, but the scientific argument is not enough. Political knowledge, political methods, policy implementation expertise are also required to inform the problem-solving skills that are going to be needed to understand 21st century sovereign behavior. The WHO's reluctance to grasp the political priorities of its member states and the structural reality that sometimes the ministries of health may not always be the best source to go to for trying to think about how to implement relationships with states means that the organisation is sometimes struggling to manage and delegate its authority. We suggest that the WHO needs to pay serious attention to the competing diplomatic priorities of states, not just to be subservient to them, but actually to try and proactively understand and build its knowledge around the orchestration of states' geopolitical and diplomatic relationships, to think about where it can craft its ability to be able to enter into this system, and the knowledge, what we call the knowledge entry points, that suggest areas that could become core business for the World Health Organization when seeking to try and optimize the conditions for a coordinated response. There are going to be more technical challenges to come. We think that the World Health Organization, surely after COVID-19, could start to try and open up the space for more meaningful engagement between diplomacy, public health, and international relations expertise. This is our call to end the disciplinary quarantine. Thank you for listening to me. I've put up there my Twitter and Claire's Twitter handle, and also the article. It's free, so but also if you want to reach out to me via Twitter, please do so. I'm going to stop screen sharing now, and I hope I didn't talk for too long. Thank you.
It was perfect, Professor Davis. Thank you very much for such a thought-provoking presentation. Basically, the idea that there is no solution outside of politics is a central one for us, I think. But we do have some questions about the politics of it, and I'll leave them for the third round of our panel. I'll give the floor to Professor Henrique Menezes from the Federal University of Paraíba. Thank you, Henrique, for being with us. He will present our comments, and we'll move forward.
Okay. Well, Sarah, thank you so much for your presentation and for staying with us this Friday morning in Brazil, but almost midnight in Australia. And thanks for all your contribution to our field. I'm not an expert in global health. I'm much more an enthusiastic of the field, and I'm always trying to learn about it. Well, but in the minutes I have, as I was asked to, I'd like to say a few things about Brazil and how the Brazilian situation now is quite illustrative of your paper argument. That we need to consider that health outcomes are also the results of political choices and political decisions. So how the dynamics of international cooperation and conflict affect global responses to the pandemic, and also the political and ideological use of critical situations like this pandemic can aggravate crisis. And for that, I'd like to start with the statement that you use in your paper, that disease don't care about governments, ideologies, or borders. But what is interesting that you go further to say that virus might not care about politics, but the political system in which they operate will have a direct impact on the success of the virus in multiplying and spreading through a community. And considering this, we can say that Brazil today, it's the perfect case of how the political environment and political decisions severely impact the success of coronavirus. At this moment that we are in this event, it's very likely that some decision or some speech from our president is compromising our ability to reduce the burden of this pandemic. So it's very hard to choose what to say about Brazil these days. But I would like to mention two aspects of the Brazilian politics that, as I said, it's illustrative of your paper's argument, especially when you mention that politics is not the same everywhere, and that different countries make particular choices because they are subject to different dynamics and pressures, and the countries will respond to demands for cooperation also in different ways. And if you allow me, I'd like to add something, is that politics is not the same every time. And as we know, Brazil has undergone such profound political changes that are strongly affecting the way the country is dealing with this crisis. Well, in general, the pandemic hit Brazil at a time of radicalization of neoliberalism, with critical effects on important public policies. We are seeing the increasing in poverty and unemployment, and increasing in our social vulnerabilities in general. As well, we are facing now in Brazil also some kind of radicalization of scientific negationism and the political manipulation of science and our scientific institutions by the government. And as a consequence, we are having some widened political disputes that affect our foreign policy and our domestic politics. And I'd like to say that reading your paper, it helped me a lot to build like a framework for me to better understand what is happening in Brazil and to connect the way the government is managing the crisis with our international relations, and how this new kind of this new agenda in Brazil is also affecting it's creating a bigger cost, social and human costs. So as I said, I'd like to highlight two things. The first, I think, it's the radical change in Brazil's engagement and commitment to multilateralism and to its own international cooperation agenda. In the last months, almost 1 year, I think, we can see many unreasonable criticism and threats to WHO, but also to the Pan American Health Organization, what resulted in the end of the technical cooperation with Cuba, Mais Médicos para o Brasil, which I'm quite sure would have a great impact in managing the current crisis in Brazil and in reducing the social and human burden of this crisis. Well, Brazilian government, it's always denying the importance of scientific evidence, the WHO recommendations. It's ramping the mobilization of resources to and adequate and a better implementation of public policies to limit the spread of the disease and to reduce the social costs. And the Brazilian federal government, it's also opened some disputes with our scientific agents, with civil society organizations, and the state governors. And this kind of political dispute generates an important political, domestic political division in Brazil, which leads me to my second example. It's the importance of a specific domestic political arrangement in creating solid options to deal with the pandemic in a clear and open opposition to the federal government. That's the case of the Northeast Consortium. I will come back to this case later, but I would like to exemplify the Brazil's role in multilateralism and its relationship with strategic partners. I want to bring the current Brazilian position regarding the global debates on IP, intellectual property rights, and access to medicines. That's a prominent topic today at WHO, also at the United Nations, with some important resolutions calling for COVID technologies to become public access. But now it's a huge important topic as well at the World Trade Organization. And as we know, Brazil has been a key player in the global debates on IP and access to medicines. Brazil played a major role together with South Africa and India and support civil society organizations in the adoption of the Doha Declaration on TRIPS Agreement and Public Health. In 2004, Brazil led the process to the approval of the WIPO development agenda, which affirmed the importance of maintaining IP flexibilities for social interests. Brazil is still one of the few countries that supports financially the Vaccine Alliance. Brazil co-founded the UNITAID, that it's an international organization that invests some money in innovations and technological innovations to prevent and treat more quickly and affordably some disease like HIV, tuberculosis. So I think there is no doubt about the importance of the Brazilian voice in the global debates on IP and health. But however, this year Brazil changed its side drastically, aligning itself with the developed countries agenda. Regarding IP and access to medicines, I think that with the technological developments that are already reported, it seems clear that the world will soon have access to a vaccine for COVID-19. It's unlikely that this disease will become a neglected one. So the fundamental question now is who will have access to a vaccine, when, and at what price? So in this context, the concern that IP will be a barrier to timely and affordable access to medicines, it's quite clear. Because probably all the therapeutics in advanced trial stages are red patent. Many of them must receive some kind of secondary patent because they are repurposed therapeutics. And the same scenario must arise for the case of a vaccine. They will be patented, or probably they have their background technologies already patented. So considering this, last week, if I'm not wrong, the governments of India and South Africa presented a proposal for a waiver for the implementation, application, and enforcement of patent, copyright, industrial designs, and protection of undisclosed information for all technologies related to the prevention, containment, and treatment of COVID. And Brazilian government, as I mentioned, associated itself with a group of developed countries that historically militates for a maximalist IP agenda to criticize the waiver proposal. And this waiver now has the support of more than 40 countries, including China. It's a critical support, but China is supporting the proposal. And 380 civil society organizations and some international organizations are supporting this proposal. Brazil, in addition to hampering discussions in the TRIPS Council, Brazil also co-sponsored a document together with the United States and Japan, which highlighted the importance of private property and market-oriented conditions to discuss the world trade system, but also IP and access to medicines. So this change in political orientation in Brazil results not only in an absolute submission to interests that do not respond to Brazilian interests, but it breaks with more than 20 years of political activism in this critical field for global health, that is IP and access to medicines. But I think what's more seriously, it can lead to a serious delay in access and availability of technologies for the prevention and treatment of COVID-19. Well, and the second example I'd like to bring, it's related to the political and health consequences of this kind of politicization of science. Well, as we Brazilians know, that is our president, Bolsonaro, insisted on advertising a drug without scientific proof, and it's associated with extremely high risks of self-medication, as something as like a medical solution for COVID-19. And the president himself made some xenophobic statements against the Sinovac vaccine because of its origin, and he said that I don't believe that the Chinese vaccine transmits safety because of its origin. And after that, and after saying that Brazil would not buy the Sinovac vaccine due to the fact that it is Chinese, and suspended the purchase of 45 or 46 million doses. This week, the president celebrated the interruption of the vaccine trials after a very suspicious decision made by Anvisa in the reason of the death by suicide of one of the volunteers. What again could probably delay the viability of the vaccine to the population and generate more unnecessary deaths. So this open dispute with the governors in Brazil, as I'd like to highlight, strengthened the relevance of a really innovative political experience in Brazil, that is the Northeast Consortium. It was formally created in the early 2019 with many short and different objectives related to social development, to attract international investments, etc. But with the pandemic, it gained much more preeminence due to the way the consortium managed the COVID crisis in Brazil in a quite clear opposition to the federal government. So as we know, the pandemic leads to a profound lack of political coordination by the federal government and a lack of coordination as well with the subnational entities and even between the federal government and the Ministry of Health. So the inability to manage, the inability of coordination and leadership of the federal government, in addition to some decisions, some actions to impose constraints and almost to sabotage some policies to control the pandemic in the states, forced the governors to assume a critical role in fighting COVID in Brazil. So in this sense, the Northeast Consortium gained immense preeminence in facing the pandemic. Just to highlight this, just at the beginning of the outbreak, the Northeast Consortium created a scientific committee to combat coronavirus. And it was an essential milestone for planning the decisions and actions implemented by the consortium and by the 9 governors that held the consortium. And the establishment of the scientific committee defined a technical body and a scientific institution to coordinate the collection of information, to gather scientific evidence, to listen to and to adapt itself to the most updated scientific guidelines, including WHO, and more importantly, to propose responses and policies to fight coronavirus at the Northeast in Brazil, but also beyond Northeast. Many other states and municipalities based their decisions on the recommendations of the scientific committee of the Northeast Consortium. Some guidelines and recommendations made by the scientific committee had important impact on the actions carried out by local governments, especially in the definition of how and for how long to implement social isolation, measures to mitigate the social effects of the pandemic, articulation between states and local health departments, guidance to use masks and other equipments, other technological equipments. The consortium highlighted the non-use of medications such as chloroquine because of the lack of information and scientific proof. recommendations on restrictions of traffic on highways, implementation of sanitary barriers. So the Northeast Consortium, which was already a really innovative and inspiring experience in terms of planning and implementing public policies, with the pandemic had its performances and relevance enhanced. So just to finish my comments, I think the political and ideological changes in Brazil put us in the opposite direction of the best scientific evidence and recommendations in combating the pandemic, in addition to causing the country to break with its political agenda. And some kind of responsibility of the federal government and this politicization of the pandemic created internal political disputes that certainly cost many lives of Brazilians. And as I said at the beginning, your paper shows very clear how we should be aware that the health outcomes and the responses are strongly affected by political choices and how the international political environment change as well the incentives for cooperation and conflict. And Carolina, if you allow me more 2 minutes, I'd like to. No, sorry. Okay, I can I can do my question later. Okay, that's it. Thank you so much.
Thank you, Henrique. It's running late for Sarah, so I don't want to push the agenda too far ahead for her. Sarah, do you want to comment, or do you want me to organize a couple of questions we have received, and you can respond to them all? How do you want to proceed?
I would just like to sincerely thank Henrique for those really important comments. I didn't get the chance to talk about regional organizations, and I didn't get to talk much actually about areas of political promise, actually, sometimes in the absence of, and I really thank you actually for raising those cases, because I think they're really illustrative. The ones, about the Northeast Consortium, I think actually that's a really great example of the importance of looking beyond the state at the federal system, which again tends to be the priority of the way in which the World Health Organization works, and actually thinking about where do you find, even in places of resistance, pockets of promise, and how can you actually, what can international organizations do to highlight and think about and capture those movements? And it's difficult, right? Because it's this constant attempt for organizations to try and not appear like they're taking sides. But then on the other hand, what's lost in those instances, we think, which is really important, is we lose the cases, we lose the knowledge. We lose the knowledge of what is trying to be done sometimes when there is a lot of immense difficulty in an environment where the federal system is maybe against those who are trying to listen to who advice. And this is a really important example. And it reminded me of in the case of Indonesia, there's been a wonderful, really important case there of disability groups that felt that their particular risk of COVID exposure was not being adequately addressed by the federal government, and it was being addressed by autonomous regions, but not by provincial regions, but not necessarily to the same extent that recognize their particular risk to COVID-19. And so it was actually the disabled organizations across a number of provinces that came together under the Disability Act, and they coordinated their response. They coordinated what sort of difficulties their disabled populations were having in access to masks and sanitizer, and being able to get out still in a way that was safe. And there was a lot of effort to collect that evidence and then present it to their governors, and then present that up to federal system. And I believe that there's been quite a bit of interest actually in that case beyond in World Health Organization. But again, I think, to me, that's also an instance where it was local groups who actually saw there was a gap in their needs and what was needing to be recognized around their particular, desire to have to have power over their situation. And the health advice and the political system had kind of not seen them. In that case, for me, it was they'd been not seen by anyone, and it was their desire then to try and mobilize and act. And that, to me, and one of the quotes by one of the persons who talked about it was said, I have the power to do this, and it's really important that it's acknowledged that I have the power and that politics responds to it. And I think that's something in the science space, when we think about the science, and particularly in the public health space, we're often thinking about it as this, this sort of instant knowledge, but it's actually one form of knowledge, and it can maybe sometimes be missing other forms of knowledge. And it also can really benefit from engaging with other areas, as you show with that Northeastern Corridor. The scientific community were able to work because there were politicians willing to have a conversation and talk about it. And I just think we need more of those examples. So thank you so much. I really appreciate that.
Well, thank you, Sarah, and Henrique, for the comments. We do have a few questions, if I may. I know we're a bit late. I think one general question relates to the issue of politicization. Henrique already mentioned it. It has also appeared in a question by Professor André Ribeiro Hoffmann, in our comment section here in the chat, meaning that politicization is a double-edged sword in a way, in the sense that you need it to resolve and try to find common ground for collective problems, and health is perhaps public health is one of the central issue areas in which collective action is required, right? So in one way, you cannot dispense with it. On the other way, we do have some examples, as Henrique has forcefully pointed out in his remarks. Brazil perhaps condenses some of the issues around radicalization and excessive politicization that have had detrimental effects on both coordination, but I would say also on individual level responses to those issues that have put non-governmental, subnational strategies also under particular strain. Andrea has pointed to how this kind of radicalization and excessive politicization has also impact on the regional level, not only on the subnational level, but also on the regional level, in the sense that it has weakened some of the regional strategies and responses and institutional and normative space that existed, that could have been used in connecting security and health at the regional level. She gives the example in South America of UNASUR, that has potentially grown out of a concern on security issues in the region, but that had a joint health policy in place, and that has been downplayed in recent years because of radicalization within different national governments in the region. So what's your take on this idea that politicization is important, but it's also dangerous if... So how do we tackle, the dichotomous issue of politicization, especially in relation to public and collective health problems? So that's one, I think, general area of discussion that we can perhaps conclude our panel with. And the second is also on the question of Edna, and I think it's an unavoidable question given the context in which we're talking, which is the changes in America's political landscape with a democratic victory on the horizon. And of course, this has important connections to different, it can trickle down in different areas, both within international relations, but also in national and subnational, transnational kinds of arrangements and changes in the global agenda that might be very relevant for how we're going to deal with the pandemic in the coming months and years. So how do you see the changes in North American politics, and the US politics in particular, because it will have effects on WHO and all sorts of issues that are related to COVID. Daisy is doing a comment here, if time permits, on why it must be a feminist global health agenda. We were very lucky to have Claire on one of our first round of panels at the Brazilian IR Association in early June, and she talked a lot about gender and the pandemic. So that opened up our feminist agenda here on those issues. So it's really nice that we're finishing up with your presentation, and also on that particular note on the relevance of gender issues. So if you can perhaps reinforce those last comments of yours on why we need a feminist agenda if we want to move forward on global health solutions. So thank you very much, Professor Davis, Professor Menezes, and I'll leave some time for both of you to wrap up on those suggestions and comments. Thank you.
Thank you. Would you like to go first, Professor Menendez, or shall I? Or?
No, you.
Thank you. The politicization question is excellent. It's one that we grappled with in the paper, because we were so aware of it's like securitization, right? It's the double-edged sword here. It can enable conversations to be. It breaks down doors. It allows you to identify priorities. There's certainly a reason why in the global health space there's been this deliberate attachment to security, and there's been a lot of talk about the fact that it's been actually the medical field that has sought security in order to sort of promote their budget and their areas in the past. And I think it's the same in politics, right? There's politicization can be a detrimental, but it also can enable to be heard and to be listened to. I suppose for us, then, in this article, what we wanted to have was the conversation. Actually, I guess for us, to come back to that quote that we talked about, that we identified in the paper by Dr. Tedros, what was really worrying us, and we're sympathetic to it, right, is this sense that politics should be quarantined. It's making things worse. It's science that's the solution. And for us, that idea that you could separate them was really concerning, because for us, what we were seeing was politicians ignoring the science, making it dangerous for scientists to do their work. And if you say that there's no then role for the World Health Organization to talk about politics, then you're effectively contributing to environments where scientists are being silenced, where they're being felt, where they're in fear sometimes. You're almost unintentionally as well enabling politicians to continue to make these comments without any sense of accountability for what they're saying. And that for us was really concerning. So for us, and also too, we just felt as well that there was a real need to disaggregate the politics, because for us, that was also what was really important, is that, and that was highlighted just before with that Northeastern Corridor case, that actually politics is not always the enemy here. And in fact, environments can have very different systems. I mean, a classic example here has been in the Australian case, where there has been a lot of politics made of the fact that Victoria went down into an extreme lockdown. Different states have been closing their borders. But that's actually been a really important conversation to have, I think, and I think it identifies the fact that we are a federal system, and, and we've got the freedom to debate it and to argue about it. And that's important. And I think that makes the rigor much better. And I also think that if anyone was outside looking in at Australia, though, through the IHR mechanism, they wouldn't see that complexity. And we're quite simple, Australia. I mean, we're very small, we're an island. They wouldn't see that complexity. And that worries me then when we're thinking about how are we helping states and thinking about and evaluating their preparedness, when our measures at the moment aren't taking into account that complexity, aren't taking into account that you know, the disaggregated state and the fact that it's more than just maybe a couple of ministries that are going to be responding to this outbreak. So for me, that's the importance of maybe talking about the politics. The second question, shall I answer all of the questions? Is that okay? The second question about Biden and the effect. I don't want to say I don't know, but I do genuinely feel I don't know with this one. There's been a lot of discussion about the fact that the Biden administration is definitely going to embrace the World Health Organization. There's some well-known individuals in their transition team and their COVID task force who have a strong support for the World Health Organization. I think we'll see a reinvigoration of the global health security agenda, which I think, you know, and we'll see a real reinvigoration of trying to promote itself as a leader in this space. I do think, though, it does come back to, though, what Henrique was talking about before, though, what we need to maybe take a step and remember, though, is that even democratic administrations tend to get a little bit nervous around intellectual property, and they tend to get a little bit nervous around, you know, how much they're willing to cede in the global space in the area of viruses and vaccines and treatments. And so I think, you know, we need to temper it a little bit here and realize that there's still going to be some tricky days ahead, even with an administration that may believe in science and want to go back to the World Health Organization. And they've got a serious, you know, they've got a serious job there to try and rebuild their domestic situation. So I think it comes back to the importance of us thinking about our own solutions and not maybe necessarily relying so much on the United States. And I think that also points to the real importance of that South Africa-India initiative, you know, that Henrique was talking about. That I think that's really important, and, you know, and there needs to be support for those types of initiatives. We can't see the United States necessarily as providing us with the answers to some of these problems. And then finally, thank you so much, Daisy, and thank you for the invitation to speak today, is the why it must be a feminist agenda. And I've just got this: 20 countries with female leaders, and 70% of our global health task force are women. Right now, around our world, we are relying upon unpaid labor. We are relying upon a high degree of people to risk their lives, mostly women. There's some situations they're doing this unpaid, you know, and on top of that, we've got big task force, big budgets, big types of consequences about what's going to happen in the post-COVID recovery. And 70%, you know, we're in the minority, women are in the minority at those tables. That's a problem. And I think that's going to be a problem for going forward. And I think that's why when we look at COVID-19, it's really important to look at who's been most affected. You know, we're not all in this together. There have been people affected very differently. And I think we need to go back and look at the fact that there has been a lot of inequality that's gotten us to this point of the way in which this pandemic is happening. And we really need to address that inequality in the recovery phase. And I think it's really problematic that, you know, when we're talking a lot about the economic recovery, including in my own country, a lot of the budget recovery initiatives are very much in favor of taking things back to as they were. And what that ignores is the fact that there's a lot of economic inequalities in our systems. There's a lot of reliance on informal labor. We're heading up to the 16 days of activism. It's all about informal labor. We know that women in informal labor have been horrifically affected by the COVID-19 outbreak. Food insecurity is going to be much higher. Again, women and children are going to be most affected by this. So for me, if we can't look at now's the time to start really thinking about, you know, a gender equal agenda in response to COVID-19, it really worries me, actually, that I think we could be doing actually so much more in this space. And I think gender equal, also recognizing as well, there's a whole range of intersectionalities within that as well, you know. So yes, we can talk about women and men, but, you know, my position is very different. And and so we need to have a lot more recognition of inclusion and representation and diversification of that as well, who gets to be at the table. And that's also part of my concern too about this focus on science, because we know that, you know, no offense to scientists, they're wonderful and they're important, but there's an elite structure there as well. So I think we need to be really attentive to this. Who gets to be at the table? Who gets to make decisions? That's also political in the science space as well.
Thank you, Sarah. I'll pass to Henrique for his concluding remarks.
I'm just going to say a few words about the question on IP and access to medicines, and the possibility of a patent break at TRIPS Council. I think it's practically impossible, the approval of this waiver, because it's suffering a lot of pressure from the United States and the European Union. But I think what India and South Africa are seeking is the strengthening and broadening the legality for a wider use of compulsory licensing. What is already permitted, but the country suffer a lot of pressures in trying to use this. So I think they are trying to make it more legitimate to use compulsory license, especially India, that it's a country with strong capabilities in producing generic medicines and vaccines. And I'd like to thank you for the opportunity of being here and share this table with you. It was a pleasure for me. Thank you so much.
Well, thank you both for such a, I think it was a remarkable encounter, very timely in the sense that it provokes us for questions that are central to our field of studies, that are important for the Brazilian IR community and for global health research. So I think this will be a wonderful resource for our associates to come back to in the coming weeks and months. So thank you so much, Professor Davis, for being with us. I know it's 1 a.m. also, almost 1 a.m. in Australia, so we appreciate very much your time and effort to be with us this morning here in Brazil.
Thank you so much for your generous invitation, and again for putting up with perhaps my ramblings at 1 a.m. my time.
It was great.
I appreciate it, and good luck to all of you, and thank you so much for allowing me to speak at the end of your conference, and thank you for the questions, and thank you for your excellent comments. I really appreciate it, and I hope one day I can see you in person.
We hope so too. I'll move to Portuguese now e agradecer ao professor Henrique Menezes pela generosidade de estar conosco também, pelos comentários muito importantes sobre a experiência brasileira e particularmente do Consórcio Nordeste, que eu acho que precisa de fato ser estudado, né, como uma experiência que pode ter, né, um significativo aí para o global, para a reflexão global sobre esse tema. Agradecer aos sócios e sócias, né, que nos acompanharam ao longo dessa jornada do 5º seminário, pedir para que continuem assinando e divulgando, né, o canal do YouTube da Abre, vem mais coisa interessante por aí, o seminário acaba, mas as nossas atividades não, então fiquem atentos para o nosso canal e para as novidades, também nas redes sociais da Abre, Facebook e o Instagram. Agradeço a quem nos assistiu ao vivo, e peço, por favor, que divulguem também a mesa que vai ficar disponível lá no nosso canal. Agradecendo a nossa presidenta, Deise Ventura, pela iniciativa, pela coragem na gestão, e a toda a diretoria e a comissão organizadora, o comitê científico desse seminário. Acho que a gente encerra com o senso de dever cumprido, de ter contribuído para os debates que são mais importantes, né, da nossa área, nessa atual conjuntura, por termos sobrevivido, né, estarmos sobrevivendo e saudando aí a nossa comunidade, as pessoas, eu acho que a frase inicial da professora Davis, né, das vítimas dessa pandemia, seus familiares, a nossa solidariedade, né, a todos que estão na linha de frente, e aos nossos colegas também que têm alavancado, sobretudo, né, o ensino público de qualidade em condições bastante adversas em diferentes partes do Brasil, em condições também de profunda desigualdade, né? Então, fica o nosso abraço a toda a nossa comunidade acadêmica, estudantil, né, por manter a nossa área viva nessas condições. Tá? Então, um grande abraço a todos e todas, e encerro as nossas transmissões aqui. Acho que todo mundo já foi.